Okay, with quorum now, I'd like to go ahead and call the meeting to order for Medical Advisory Committee. Thank you all for coming. We're going to go around and make some introductions. We'll start with Teresa to my far right.
Teresa Rios, EMS Agency.
Jared Bagwell, EMS Agency.
John Burley, EMS Medical Director.
Jeff Warner, CalStar.
Tina Nieto, Lachis.
Cassie Caldera, Natividad.
All click, Natividad.
Michelle Flensky, John.
Scott Houch, Union County Chiefs First Responders.
Will Heller, AMR.
Oh, me, Cindy Williams, field paramedic.
With AOR.
Jim McConnell, Mercier.
Reno DeTulio, CAL FIRE.
Eric O'Reilly, Monterey County Regional Fire.
David Stanovich from County Fire.
Doriano, AMR Operations.
Mike Eslinger, AMR.
Tom Woodland, EMS Analyst.
Laura Waller, EMS Agency.
Roxanne Sokasat, EMS Agency.
Steve Brooks, EMS Agency.
Okay, thank you. And particularly welcome to our newest member, Will, who joined the committee as of about, 30 seconds ago. So thank you, Will, for hopefully your long and prosperous career will continue here. Appreciate it. Thank you. I'd like to open up now to forum for public comment.
Well, maybe if I can make an announcement. I'm not sure if everybody received a notice, but we'll
Announcements at the end.
Oh,
I'm sorry.
Just this
Sorry.
is public,
I'm
though.
sorry.
I
Go
can
ahead.
make a
Go ahead.
statement. That Will Hiller and Ben Hitchcock actually have accepted positions as CES specialists. So we have 2 specialists now on our team, so we're excited to have them with AMR. So congratulations and all that. Thank you.
Okay, thank you so much, and we'll go ahead and move on to approval of past meeting minutes. Has everyone had a chance to review the minutes?
I'll motion approval.
I'll second.
Okay, we have a motion and a second. Does anyone need more time to review the minutes? Okay, all in favor?
Aye.
All opposed? Okay, the minutes are approved. We'll move on to EMS recognition. I don't think we have anything specific for this month, as well as correspondence. Nothing specific.
We do have 2, yes.
Okay.
We did receive correspondence related to the MAC meeting, so I'll just kind of summarize. They were both emails to the committee. One from Devin Haggy from Fort Hunter Liggett. He wasn't able to attend, but he wanted to express his support for the expanded scope EMT. And one from Felicia Fisher, as well as her voice of support for expanded scope EMT.
Thanks, Jared. So we'll move on to old business. First responder response times to EMS call update. Jared Bagwell.
I'll go up and- Okay, everybody can hear me? Just an update on the first responder response times. The EMS agency has reported on this before. We continue to collate the data. Once it is actually validated, we will submit the information to the fire chiefs for review, and that's kind of currently where we still are. So I don't know if anybody had any questions of me of that.
I have a question for you. So this can be a quarterly report, a semi-annual, what are we looking at?
We haven't made those decisions yet. We're just trying to get the data, compiled first, and then send it out to the respective districts and kind of go from there.
Is there a desired outcome, or what are you looking for in the data?
We're just looking to establish what it is exactly.
Thank you, Jared. The next item on the agenda is EMS systems communication policy update.
Yes, I did provide a staff report. I'll kind of summarize. As the committee may be aware, the EMS agency worked on some EMS communication policies over the last year. They were implemented partially in September. They're pretty much mostly in process right now. As you may be aware, Senate Bill 438 was signed in October. What that did do was establish some public safety duties related to call processing. So the EMS agency, 911, and the fire districts will be meeting next week to discuss some of the impacts to those policies. At this point, we kind of feel they may be relatively minimal, so we can report back to the committee after that meeting and subsequent changes that might be needed.
Jared, may I make a comment? I respectfully disagree that the changes are going to be minimal. I think they're going to be significant. And of course, we'll talk about this during these meetings. Just to cite a couple examples, we're already seeing changes that are impacting all agencies operationally. For example, the lift assist ambulance response is impacting not only the ambulance provider, it's providing agencies that provide mutual aid. So that's already had an impact. The change in call type, where we're getting priority 2 calls. System-wide, there's some confusion as to how to interpret and what that means. So I think we could do a better job of educating agencies as to what call types actually stand for. My suggestion, and I'm sure we'll go into this more at EMCC, is I think the first thing we should do is outline the process and get buy-in from the whole set of groups that meet that are impacted by this issue. So this is just kind of an initial comment, but I think we should learn from the difficulties of the last year and start off with a group buy-in as to what we're going to do going forward.
Thank you. Any other comments regarding?
Yeah, no, I think we had a pretty productive meeting. I think there's an opportunity to work together that has materialized. And Nick Chulos has added some great direction that we process this stuff and keep it within the committees that exist rather than creating new committees to try to subvert this whole process, because another committee will just extend our times. I don't want us to have a policy like San Joaquin County that's 37 pages long, but Eric's absolutely right. We don't have the definitions. When Lift Assist came out and directing people to policies, Jared forwarded me some stuff, but they have nothing to refer to. All they knew is they have a different outline or a different response criteria for today, and they're not sure how to take it. So the critical aspect is to roll out, whether it's a packet or some sort of processing document, but for the boots on the ground, they need to know that direction. I mean, they get wobbled pretty quickly when their normal criteria is changed.
Any other comment? Thank you for those comments. We'll move on to the 2019-2020 policy implementation update, and Steve Brooks is going to update us on that.
Good morning. The 2019-2020 policy updates, you've all received those. They've been distributed, they're posted to the website, and they will be in effect on January 2nd. We're in the period of time where the agencies who are to be using these, fire departments, ambulance providers, hospitals, are to be training their staff so that they will be ready to go and functional January 2nd of 2020. So if there's any questions about the process, it's been distributed and the process has been launched. If you have any questions, otherwise we expect everybody to be ready to go January 2nd.
Thank you, Steve. Any other questions or comments on that? Okay. So we'll move on to new business, and the item is EMT scope of practice. Steve, take it from here.
Sure. So one of the things that the medical director is able to do is, under Title 22, there are, for the EMT scope of practice, a basic scope, and we've been utilizing that for our EMTs in Monterey County. There's also included in the basic scope for EMTs the use of some other medications and procedures, including naloxone, glucometer, and epinephrine autoinjector. These are basic scope, however, they require a specific approval by the EMS Medical Director to utilize those. With the opioid crisis in full swing in many areas of the country, the use of naloxone has spread beyond the typical medical provider to, as we've talked about previous meetings, librarians, which seems incongruous with our EMTs not being able to use naloxone. So we are proposing a scope of practice change for EMTs to utilize naloxone and also glucometer, and we'll be initiating some discussion about epinephrine and whether that's going to be feasible in our system. So if we update, and Jared, if you would bring up the, it's not, it did just a moment ago. All right, within your packet, hopefully you have it, we have a staff report with a list of policies and protocols that will be changed simply by introducing naloxone and glucometer into our system for EMTs. And so in addition to the policy for EMT scope of practice change, there are 10, I believe, 10 other policies and protocols that will be changed and will need to be updated. Now, most of these changes are pretty minimal, as you will see, hopefully, when we get this up and running. So, just to run through them very quickly, and I'm sorry that we don't have this up on the screen for you. The first change is the EMT scope of practice, which would add the additional skills of naloxone and very good. Okay, go down to second page. There we go. All right, so the language is a very close adaptation to Title 22 language that will allow EMTs to do naloxone, intranasal. You'll notice it says intramuscular. We'll talk about that in a few moments. And then finger stick blood glucose testing. So it will become part of the basic scope for EMTs in Monterey County. What that will do is change the next policy, policy 2011, which is the EMT expanded scope policy, which currently has those 3 skills of epinephrine, autoinjector, naloxone, and glucometer in. It has in this scope of practice has those skills. If we move it to the EMT scope of practice, it will then come out of the EMT expanded scope of practice. And so you'll see it's basically, this policy is just a deletion of those. The next policy that will be changed is EMT expanded scope accreditation, and that's really, again, just talk about the same thing, removal of training having to do with the glucometer and naloxone. And then the next policy that's changed is policy 4020, which is the authorized stock for BLS. The inclusion of naloxone and glucometer test strips would move over to the column for EMT.
So Steve,
Yes.
I know you said we'll talk about the IM versus intranasal, but it kind of, I mean, the question that I would have is, what are you stocking? Are you asking them to stock the 2s, the 4s, the nasal, the auto injectors, and those types of things? Because if you're going to change it, you kind of need to specify and figure out what we're putting on there.
That's correct. So at the basic, and since the questions come up, at the basic level, it would be for EMTs to utilize the same as law enforcement, the 4 milligram intranasal device. That would be what we would consider to be the standard and need to be stocked.
So then
on
your
BLS
minimum
units.
stock would be 2 intranasal devices and not the auto injector, the 4 milligram tubes packages. Would that be your minimum stock? Because right now what we're seeing is, I mean, obviously, unfortunately, we're seeing really high doses of naloxone in the adult patients because of what's out there. So 2 doses is not nearly enough in a lot of cases. And if you're using these in really remote areas, where are you going to draw the line with your minimal stock, especially nasal in kids? The reason we can get away with 4 milligram dosing is the absorption is inconsistent. So if you got a 3-year-old that picks up one of these tablets that's super potent, you may need really high doses to get through.
Correct.
So if you're, I don't know, I just think that the key parts of this policy is really, are we giving it auto injector? Are we giving intranasal, particularly in kids where the absorption is less reliable? And then how much are we stocking with
Okay.
what's going on today?
So at this point, we would be looking, I believe, can you find the naloxone? Oh, there it is. It's just one, is that's what we're saying. If that seems to be that we need two, we can certainly do that.
I think our law enforcement all are carrying two
Okay.
minimum, and we have 2 doses. And the thing that really, so when you go back to your initial policy, you're talking about titrating. You can't titrate an intranasal dosing, and your only titration is you then would increase your dose limits to 8 milligrams total. It's interesting because then your ALS providers are limited to a much lower dose, which is surprising. Particularly in your adult policies. I know they're giving injectable, which is more reliable in kids, but what we're seeing today, especially with the most recent batch of drugs, is really like 16, 20 milligrams and then running drips for hours in the ICU.
Yeah, so law enforcement is carrying 2 doses for each person.
Right.
So, and, calls like that, it's gonna be more than one person. SWAT and some of the specialized units are actually carrying 2 doses on person for entries now.
And if anyone's interested, there is a town hall at the Oldemeyer Center. I think it's today or tomorrow. I think you guys probably got the information, and they're actually giving out free naloxone to carry on your person, which costs $100 or so a pop. So
again, if EMTs need help, just call us.
Yes.
We'll help out.
I mean, honestly, you guys are the source, right? We stopped you guys first because it was
Right, yeah.
easier to deal with prescribed safe, and came to your meetings and you guys were on board, so we were thrilled. But I think that the biggest part of this policy is clarifying that and where your outreach is. So if you're using your EMTs in remote areas where you don't have ALS access and you want to be able to have them help this person survive, you're going to need much higher doses, much higher, many more than 1 intranasal spray.
Sure. And not to be argumentative, but I don't see them dying from,
Steve?
once you do that.
I just buried a
I just-
16-year-old at my facility dying
Oh.
from an or a narcotic overdose that didn't
And
survive.
Right, and the reason for that, you gotta be VM, you can oxygenate.
Steve, I agree totally with Dr. Pointy, and like to see at least a minute out of 2, only from personal experience within the last 30 days. I had someone where the 4 milligrams IN intranasal did 0 response because of exactly what Dr. Polinsky said. And so it wasn't until we gave IV Narcan that it still took him 8 minutes to start breathing on his own. And I see it would be just one first responder in Big Sur, South County, it would have 0 impact. And it's almost kind of frightening. So this person I had was dead and came back by that second dose.
And I would say, Steve, one other thing is anytime you can avoid having to run the risk of taking over an airway and bagging a patient allows you and affords you the possibility to avoid complications. And unfortunately, if you say you can just bag them, it leaves you a little bit, how should you say, hoping that that's the case. Because if you've ever had an airway that you couldn't bag and ventilate, it's a clean kill.
Yeah.
So you don't want to end up in that situation
So-
with an EMT that can't take that airway over.
Right, so what we're doing is, right now, ventilating patients at the BLS level. We're adding a skill of naloxone to help with airway management, help with patient management. I accept your point. In fact, we would increase for EMT and EMT scope of practice to have, EMT expanded scope have 2. I think that's a reasonable start. Again, EMTs will not be the only people arriving. They will hopefully will be first. We also have law enforcement who will likely be there, as well as our paramedic provider, from the ambulance. So, in waves, we'll get it.
I think what you said though about bagging is important though, to not be overly reliant on the medications, because if you give the dose, it's not going to work right away. Even if you give a second dose, it might not work right away. So to ensure that while you're waiting for that naloxone to hopefully reverse the action, that people are being appropriately bagged if they're able to be.
And then I just want to add that law enforcement won't always be there. If it comes out as a medical emergency, we're not going to get dispatched. We only get dispatched if it comes out as an overdose or, a man down or woman down. So it's not guaranteed that we will be there.
And it's
So-
the EMTs will have naloxone.
Right.
Yeah, so I mean, just even so, with the policies that you wrote as the way they are, your minimal stock right now doesn't match your policy. So you definitely need to change it, because right now you have naloxone up to 4 milligrams intranasally, and then may repeat ×1 on the policy. So you're either carrying 2 milligram naloxones to get to a total of 4, or you're carrying 4 and you need to get 2 on board, and you gotta change your maximums on the policy and just revise those.
Thank you. These are all good points and good discussion. And I just, from my standpoint, I just wanted to add 2 other caveats. One is obviously, you know, this is something that naloxone is a life-saving intervention, and however, there are some caveats in its administration, and obviously you want to make sure you're titrating to respiratory effect, not to full consciousness. There's plenty of cases in which patients come up, you know, homicidal, and there's been there's been a firefighter killed from a patient who was successfully resuscitated with naloxone, then pulled out a gun and shot him. So that's something just to be aware of. You know, it may be reasonable to do a weapons check on these patients before you bring them up, and also just be aware that you're titrating to respiratory effect, not to full consciousness. The other thing that I just wanted to mention, a concern that I had in this policy is you know, by reversing the narcotic intoxication, it is a transient event, right? And so we're temporarily improving the patient's respiratory effort, in some cases level of consciousness. But as I think all of us are aware, in the emergency department setting, these patients often need multiple dosing, often need to be put on drips. These patients can certainly end up in respiratory arrest again later on down the road if they're not dosed again and if they're not observed. So I think it's really important, if we enact this policy, that this is not something where patients are given a dose of Narcan and then we're happy to let them sign out AMA. That could be a fatal error. And so I want to make sure that we understand that these patients should be still going to the emergency department. They need to be observed. They should not be signing out against medical advice as much as we can help it. Any other comments?
And Steve, this is January 2nd implementation as well?
We're going to talk about that. That's the intent. We'll talk about process here once we get through the policies. All right, so that's the minimum stock. Next is the protocols, overdose and poisoning. This is the adult overdose and poisoning. We've moved if you can go down just a little bit more. So we've taken the information from the paramedic side and basically moved it up for a specific treatment to, and go ahead back up to the BLS side. Up to the BLS side for suspected narcotic overdose, we will have naloxone up to 4 milligrams intranasal, and then may repeat 1 time. That's on the BLS side of things. Now, we have in our scope of practice policy, because it's what Title 22 allows, is intramuscular injection of naloxone. I've left it there. This is going to be part of the discussion of where we move forward, because we have EMTs on paramedic units, engines, ambulance, that may be able to give naloxone while the paramedics, dealing with other things. It would be within the scope of practice. And so to not have additional requirements for paramedic units of an intranasal device, we can certainly go that way. It would allow EMTs who are on a paramedic unit to use the equipment that's there and a ion injection of naloxone. We think that's reasonable. It will require additional training, more than likely beyond what has been done as far as for the EMTs, a renewal of their certification training. So we'll talk about that. And I'd like to have any discussion, any thoughts along those lines? Help us write this policy so it fits for what people would like to do in the field, and then what's medically appropriate. So the thought about IN and versus IM for paramedic unit at EMTs?
Yes.
Do you-
Absolutely.
Now, the nuance of it, do you also want to write in for paramedic units to stock the intranasal devices, or just leave it as is with the injectable?
We already stocked that.
Yeah, they're already
They're already giving them.
All right.
Yeah, yeah, adding that language in would be fantastic.
I think probably the biggest thing to change on ALS though is your dosing limits. You've got dosing limits that are really low on that. Maybe I'm looking at the PEDS policy. But either one of those, the intranasal for PEDS is gonna be a standard. You can get a 2 milligram, but if you're buying 4, I mean, they're both approved. So you should probably get just one and save costs. And change those dosing limits on.
So here's how the policy's been written. This is, what paramedics can do on standing orders under the EMS Medical Director. Should a suspected narcotic overdose, as we know, many of them have significant levels of the narcotic in their system, require additional dosing, in which case they can always contact the base hospital and have the base direct as much as they're comfortable giving. But this is for the standing order piece.
So I think that when you have something where you're approving a lower level provider up to 8 milligrams, you should probably let your ALS providers have that same leeway. And then if you want to go beyond that, fine, you would need to make base contact. Every time you make base contact, obviously there's delays. You're grabbing one of us from whatever we're doing and it's going to delay patient care. You can usually bag through that, but at least get them consistent with the EMT levels and what's pretty standard out there. I mean, there's obviously a lot of risks that come with doing something like this with naloxone. There is the risk of precipitating withdrawal, pulmonary edema, all kinds of things, but nothing is beyond what we're seeing with the risk of dying young people. So,
I think it's a good point. If we're approving BLS providers to up to a certain milligram maximum dosage without medical consultation, then I think the ALS providers should also be approved up to that maximum dosage.
8 milligrams. Okay. All right.
Can I back up real quick? Just to be clear, so IM injections will only be available for BLS people working with ALS?
Correct.
Okay.
That's the intent.
Okay.
I mean, this is the time to discuss if you'd like to propose something different, but that's the
Well, I'm just curious for myself because I'm BLS only, and so that would just want to make sure that that's going to rule it out completely. That's I just want to be clear.
unless you want to present that.
I would be willing to do it and teach my guys up to that level, but it doesn't matter. Either way, it's fine.
All right, so that's the overdose and poisoning policy or protocol change. The next one is CVA policy, and this allows for the use of glucometer, same as we have for paramedics. It didn't mention it in the paramedic side, so there's no changes in the deletion, but it's been added to the BLS care to do blood glucose measurement for suspected CVA. This will be the same as for seizures. Next one, see. Again, allows for a blood glucose measurement. We have it in the paramedic side, so move it up to BLS. For suspected hypoglycemia, just take it out, move the language up to the BLS side of things. Now we get to the overdose report for pediatric. And again, substance specific, took the language from down below, paramedic side, moved it up, except it limits to the IN. And do we want to, if you would hang just a second. think that's what it was. So if we go to the paramedic side of things, do we want to also increase the dosing?
I think you need to, because your nasal, if you're only gonna carry 4 milligrams, that's gonna be your dosing. They obviously have more leeway to weight-based dose appropriately and titrate. The other thing about the language in the BLS is I'd probably take away titrate and put something redose for persistent respiratory depression. You know, rather, because you can't titrate the nasal spray. It's not like you can squirt part of it. You just gotta give it, and then if it's not working, you can redose it.
So what was your language again for the?
Redose for persistent respiratory depression or respiratory rate less than 10 or whatever you have up there. But it's a pure, you know, you get the full dose, you don't titrate it, and then you can repeat it.
Okay, thank you. Any other comments on this one?
Just want to again stress in training here that we're dosing to respiratory effect, not the consciousness. I think it's important, you know, that we're not just getting on scene, suspected narcotic overdose. Let's get the Narcan, spray them, let's see what happens. If they wake up, oh, we have our answer. That's probably the wrong way to go. So just be very careful and specific in training to make sure that providers understand why we're giving this medication.
I think most paramedics in the field know exactly why we're giving that medication.
Agreed, but we're also there's these EMTs, there's you know BLS providers that are part of this process as well, and I'm sure they also know and are comfortable with the concept. But I can see the temptation if you have an unconscious person, you don't know what's wrong with them, to give Narcan just to see it as a diagnostic tool. We do it in the ED sometimes, right? Yeah, and so, but it's a controlled environment in the emergency department. We have the resources to handle a patient if they come up swinging.
Steve, one thing you might want to consider on the PEDS policy under ALS is to separate out the Narcan intranasal from your other modes of administration. Your other modes are best probably weight-based, dosed and titrated to effect, especially the IVIO. And the intranasal comes, you know, as a single dosing regimen, so you can't titrate that. But I would maybe put 2 lines. They're allowing if they're gonna be 4 milligrams stock, then, you know, intranasal 4 milligrams, may repeat times 1, and then have the other as your weight-based appropriate dosing.
Okay. The next protocol is the seizure pediatric, which is affected by having glucometer. So we can add glucometer to the BLS side, and we can remove it from the paramedic side. And then hypoglycemia pediatric, again, it's just removal of blood glucose measurement as a paramedic skill to now it's a BLS skill that the paramedics will also perform. That completes the policies and protocols that would be changed by adding naloxone and glucometer to the EMT scope of practice. The implementation of this, we would desire it to be saying for ease, for training, for implementation of a policy and protocol change is January 2nd of 2020. I think all you guys could make that happen. I think everybody wants it to happen. We have a policy and procedure development process policy that asks us to bring these policy changes that we make here in this meeting back to this body for endorsement, which would then be after the implementation date. So to manage that, I have a suggestion, if it's acceptable, to move this through the emergency policy process, and we could clearly consider the opioid epidemic and something of an emergency so that we can get the naloxone into the hands of the EMTs more quickly. We can put this into place effective date of January 2nd. We can launch the public comment process to coincide with this. We'll put out the training, bring it back to the committee meetings in January for review, and it says, you know, an endorsement vote. We would ask for that at the January meeting. If you're acceptable with that, that's kind of the plan to move this forward to make it easiest and coincide with the process that's in place right now. Any comments?
So can I make a motion for that at this point?
You can make a motion.
To the chair,
make a motion.
you know, because I mean, this doesn't meet the definition of emergency, there is nothing that meets it. This is a quick, swift change that is well known to virtually everybody in the field. So it shouldn't take more than that period.
So we have a motion on the floor.
I'll second.
Second? All those in favor?
Aye.
All those opposed?
What was your motion exactly?
The motion to term this as an emergency change, the policy procedures, I think it's policy 1000.
To move forward with
To move forward with
the modification of the
emergency
policy.
action to protect the public.
To move this forward for January 2nd implementation, followed by committee meeting, review.
Motion carries.
All right. The next piece on this I believe is, we have epinephrine on the agenda?
Mhm.
Good. So epinephrine, we would like to have this considered for EMT use also. Most people think epinephrine auto-injector, and that is what we would be proposing to bring forward. We also know that the cost of moving epinephrine by auto-injector for EMTs out of the EMT expanded scope of practice to the EMT scope of practice would require all BLS providers to carry epinephrine auto-injector on their responsive vehicles. And that could be a significant expense. So the EMS agency at this point is asking for your thoughts as to whether this is something that is desired and if it's financially feasible. Because we don't want to put something out that gets pushed back simply because it can't be.
Steve, I think it is desired, and no, it's not cost feasible. My recommendation is that we explore if it includes additional training or additional delivery methods, that we look at more cost-effective means of providing the medication that is necessary, the training that is necessary in a much more cost-effective manner.
So
I don't have specific products that I could cite. You and I had talked offline about a company that has like a rubber seal on a syringe where you cannot administer more than a set amount. So I'm willing to look at what's out there, see if we can find something that's more cost effective and still get it out into the field.
okay. Any other comments about FB by
I
auto-injector?
can tell you from our end, if it is not cost effective, we're financially gonna have a hard time dealing with that, especially with the expiration date and our use of having to carry it on everything. I mean, I have 30 EMS bags that I have to carry it on. Now to carry for every rig that we have, because we don't know which will be taking that time. And then for it just to expire and the shelf life, and the chances of us actually using it or could happen, so we need to find an affordable way for us to be able to do it.
So purely for speculation purposes, epinephrine auto-injectors, and if anybody has more current information, seem to cost about $200 each.
I think it's more like 300.
Is it more like 300? Okay, that was my last look. It's, again, very expensive. There's systems that I'm aware of that I believe, and again, this is speculation, last information that I can remember, are about $60 each for injectable system where you use you draw it out of a ampule and inject it. It's $60. Is that feasible? Is that still sort of cost prohibitive?
I don't know exactly. I'd have to bring this back to the chief to
Sure.
see for sure. I just know that we're in financially hard times right now, and so this additional cost come to us is not ideal.
Right. Okay.
So-
That's what I was looking for.
Steve, looking it up, you've got 2 2 auto injectors, $120 at Walmart for EpiPens. So you might be able to find better prices than what you're at with Taxi.
They sell on Amazon too?
Yes.
I haven't checked Amazon, but I got Costco at $135, Walgreens at $134. So.
Or the other option is to just change the protocol so that you transport directly to Walmart.
That'll work beautiful.
That's brilliant.
But anyways, at 2 of them, you gotta think that, if you only have one in your stock bag for EMTs, maybe it's not quite as cost prohibitive. That's
Otherwise-
the adrenal click is cheaper than the EpiPen though. There's generics coming out now. So,
Could the BLS provider scope of practice be changed such that the BLS providers could just have the 1 milligram or 0.5 milligram vial, a single
and draw it up.
needle, and you drop either the pediatric dose or the adult dose, like it would be on the EpiPen, or just 2 options based on the patient size? I mean, if it's a kid, you're probably not going to hurt them with a small dose. If it's an adult who has cardiac disease, I mean, if they're truly in anaphylaxis, I think the benefit probably is in giving the epinephrine. There aren't that many medications that you can give that you can truly save somebody's life quickly, and I think epinephrine is one of those medications if you're having anaphylaxis. So I mean, I don't know what the cost difference would be and for simplicity in stocking, if the BLS rig carried I think it's a 1 milligram vial and either drop 0.3.
We're talking less than $20.
Yeah, I mean, it'd be extremely
It's way cheap.
inexpensive, and if it's just it's not like you're having to drop 20 different doses depending on patient size. It's either a kid less than this many kilograms, you give this dose. If it's somebody that's more than this many kilograms, you give this dose 1 time IM. I mean, the auto injectors aren't actually that simple. If somebody's got a little bit of medical training, it's pretty easy to just draw up with a syringe and administer a syringe instead of figuring out which cap you pull off, which button you push, and which side goes down and you push it in.
Went through my thumb when I tried to do it at
Yeah, so that's a pretty common occurrence, is
I was a
the
kid.
epinephrine
I wasn't
injector
allowed. I was only
into the
allowed
thumb
to
and not into the thigh. So maybe worth looking at what it would cost to train EMTs to change the scope of practice and to come up with a protocol with just the adult dose and the pediatric dose, kind of analogous to what the auto injectors are.
Well, one thing that our contract actually has the pass-through purchasing, and Tina just looked it up, and we have injectors for $53.
Really?
That's pretty cheap.
Oh.
So it's
Cool. I suspect we'll be bringing this back. Yes.
Yeah, so thank you. Those are good topics of conversation and thought. And just from our standpoint, this was something that we philosophically are for, but just don't want to overburden the stakeholders in terms of financial implications. And so we're happy to continue to look at this and work with you guys on how we can make this happen in a cost-effective manner. And just in general, thank you for bringing your concerns 2 months ago to the EMS agency. I know that this has been an ongoing discussion. It wasn't just, my first meeting that I arrived and heard this, but I appreciate bringing this information to us, letting us work with it, and moving forward in a collaborative fashion that's, I think, ideal for delivering good care to the citizens of the county. So thank you. Any other comments before we move along? So we'll move on to EMS System Quality Improvement Program, and Laura has a report for Continuous Quality Improvement Technical Advisory Group.
Good morning. So the CQI tag is not met since the last time. CQI tag and TQIC meet tomorrow, so I will not have an update on those. Other than with CQI tag, I would like to recognize the providers for sending in their QI plan updates. That's very helpful. Please understand, we approve the QI plan itself initially, and then every 5 years. The update, you will not get a letter from me saying that it's approved, because the regulations don't say that the update needs approval from us. But it does get filed and noted, and you will get an email back acknowledging that I received it. So thank you to those agencies that have done this. For STEMI and stroke, there are POTI forms in your packet, but for people who didn't bring it, for STEMI, what did we have? I'm going to start calculating scene times both by the first responder on scene to transport time and transport provider to transport time. So we will have a couple of different scene times for that. There were issues with Salinas Valley working out issues with getting the PCRs. We will get an update from that. The last I heard that's working well. We were asked to make a couple of changes to aspirin administration. We've been tracking that, and it was suggested that I have documented or not documented, and and we are adding contraindicated. I am still attempting to get the numbers of walk-ins on both STEMI and strokes, but I am only receiving data from one hospital, so I'm not able to do that comparison. And then because STEMI regulations and stroke regulations as well came out in July of this year, they do require site visits every 2 or 3 years. I can't remember exactly which, but I'm going to make an attempt to schedule those site visits. The hospitals will get advance notice well in advance, along with the checklist that I will be looking at. And we are working on getting a list of minimum data elements and mandatory fields for PCRs. The state has come up with new requirements for this that will be taking place January 1st, and we will be discussing that at CQI TAG. I'm also measuring not just door to balloon time or EKG to balloon time, but also first medical contact to balloon time. And we will be discussing standardizing the practice of transferring STEMI patients. Some other things, providers need to remind crews to keep the scene times as short as possible. That's one of those elements that they can control. And we'll be looking at under triage of STEMI patients. And with AMR, if they end up taking a picture of the first responders' EKG, please make sure that the picture is a really good picture because it's difficult to read at the hospital. For stroke, EMS agency will put we're looking at selecting a large vessel occlusion scale. So I'm going to put together, we've narrowed it down to 3 of the scales. I'm putting those side by side for comparison for discussion at the December meeting. We're going to add under triage and stroke transfers to the list of metrics. And again, providers need to request their crews keep scene times as short as possible on stroke calls as well. Are there any questions?
Laura, just real quick, I know a lot of times long on scene time, and I know there's a button for that on ESL, but I don't know if all the crews are aware. A lot of it is due to extrication, because usually most people are upstairs in the way back 200 to 300 pounds, and that takes more than 10 minutes.
It does.
So I've been making sure that I tell people I train to make sure they click that, so you get a notice that the extended on scene time, and then I write in the narrative that
And I read
a
through the
circuitous
narrative.
route.
I read through the narratives. There absolutely are good reasons for extended scene times. It's when you can. Any other questions? Yes.
Laura, you said you're not getting outcome data from STEMI and stroke in 2 of the hospitals.
I'm getting outcome data from one of the hospitals. We are in discussions with the hospitals right now for what data will be shared, when, how, all that. We have, this kind of goes into, I think, the next, we are still in discussions with the hospitals, and that's, once we finish meeting with them, we hopefully will be able to get outcome data, not just on STEMI, stroke, and trauma, but also on most of the patients. We are, like I say, we need to finish discussions with hospital administrations.
When are those going to take place?
We've had several. We have one tomorrow, and I don't know. We've got to discuss the process once that's completed.
Okay.
I can't give you a time frame.
Yeah, just wondering, how can we really have a meaningful stroke or STEMI if we're not getting feedback from 2 out of 3 hospitals?
I agree. And it's 2 hospitals. There are only 2 designated stroke and STEMIs.
You're not getting feedback from Sean. We've got one STEMI receiving facility, and I mean, Laura can go into it if she wants in terms of the issues, but I have all the data. We're just waiting for a consensus on, everybody reporting and standardizing. It doesn't seem like, for a very long time, we would submit all of our data, all of our trauma, everything else, and the other facilities were not submitting data. And so we came to you, the EMS agency, and said, let's get to a consensus, let's figure out what we're studying and why. Let's make sure that the data is secure when we get full outcome data, who's gonna have access, how we're gonna utilize it, and what we're gonna do. And let's get everybody on the same page. And so I literally am sitting on a year's worth almost now at this point, maybe 3 months less than that, but of trauma, STEMI, and stroke data for my facility. As soon as they give me a consensus, I'll have full clearance.
Right. And I opened this door somewhat intentionally.
I know you
because
did, and that's
on
why
the
I
EMS
spoke up.
On the EMS side, it is so incredibly frustrating. I get a daily report from CHOM, SVMH. I do have a contact. It's very, very difficult to get information. Natividad has changed their policy where the 2 trauma coordinators who I could call on a daily basis are no longer authorized to provide information. It now goes through one individual who, through no fault of her own, is so incredibly busy, it might as well not even exist. So this is a system-wide problem. I think it should be a top priority. We're just not getting outcome data. Obviously, the pre-hospital providers are not getting it. The EMS agency is not getting it. The hospitals are frustrated. I mean, this is a major issue.
And we are working on it. Sadly, it's not a quick process.
No, I know, it's been going on for years.
Any other comments or questions?
I just wanted to add to that, that additionally with the lack of outcome data, there's a lot of anecdotal stuff that gets discussed in the ER because we don't have any information. So doctors will come directly to the medic and say they would prefer or whatever, but it's not policy. It's not like, we can't track that, you know, there's no information at all. It's a lot of that is happening. So, the sooner the better.
I have a question too.
Yes.
Airway data outcome. So how is that going?
We are in the process of validating that data. I was hoping to have it ready for tomorrow's meeting, and sadly, I'm not going to be able to, but we are actively working on that, ensuring that the information we put out to you is completely accurate. Any other questions? Thank you.
Thank you, Laura. So we'll move on to reports. Emergency communications drill reports. Jerry?
I do not have a copy of the communication drills, but they were provided in the packet, and I'm available for any questions if anybody had any on those. I can summarize, the performance has been similar on the MCI and the 800 drill performance. Many facilities meeting the 95%, some still not, but just shy of the 95%.
Have you identified the challenges of why they don't meet the standard?
I think it has to do with, I know, can anybody speak to any of their facilities?
I know a lot of times it's right at our change of shift, and our charge nurses who answer it are walking around doing bedside report. I've been there several times where I've stood there and was like, oh crap, it's going up, there's nobody. They're actually with patients. And a lot of times too with the 800 megahertz, we know we're the first hospital, you'll hear radio noise, but it's not clear coming through. You get halfway through, and now you hear words on, on the radio. We're like, oh, that was probably us because it's the first call out. So we know to answer it, but at times it gets missed. There's a lot going on at our nurses station.
Long-term goal is to replace the 800 megahertz radios and incorporate them into the next gen system, but that's down the road. That might help with some of the quality.
Thanks, Jerry. And then we'll go on to ambulance patient offload times?
Yeah, we had reported APOT times last meeting. Those were AMR APOT times. We pulled that report for this meeting because we are going to start reporting system-wide APOT times. We are required to report those to the state anyway, so we're in the process of ensuring, validating that as well. ESO has been around for about a year, but there are some hiccups with pulling the data, so that we'll work through those, and I think we should have something for you on the next meeting.
Thank you. So that moves us on to future agenda items. Any specific items to discuss? And then we have announcements. Teresa, you want to make any announcements?
We want to give an update on our EMS staffing. We want to introduce and welcome Thomas Woodland, our EMS analyst. If you are okay, Thomas, would you like to say a few things about yourself?
I've been in EMS for 12 years. The last 2 years, I was a field supervisor for an ambulance company in Santa Clara County. Previous to that, I worked 10 and a half years in the 911 system out of Tulare County, which is very cool. So I do have a lot of knowledge and experience in the EMS field, and with the partnership of all of our fire and ambulance providers, I want to help out wherever I can within the EMS agency. I have a laundry list already. I just got that yesterday of what I need to accomplish, and I'll be at your service at any time you need. Thank you. Thanks, Thomas.
The other announcement is that Fred Claridge left the EMS agency. He is now working for the Office of Emergency Services. So he's still with the county, just in a different department. And then Michael Petrie, as everybody knows, announced his retirement. His last official day with the county would be November 15th, so Friday. And that position will be recruited for. In the meantime, I am acting EMS Director.
Thank you, Teresa. So then we move on to the next meeting date, which is going to be on January 8th of this upcoming year. Yes. Something? Oh,
There's some
what's that?
announcements.
You-
Steve had something.
Yeah.
Oh, sorry, Steve, you had announcement regarding EMT medical accreditation applications.
Simple announcement, EMS agency will be on if anybody's actually here much, will be on minimal staffing as with most of the county offices around Christmas. So if you have anybody that's coming up for EMT renewal, effective December 31st expiration, January 1st needing to be continued certification or accreditation, please get the applications to me by the middle of December, no later than December 19th, I believe, if you want to be very certain to have it approved and go through before they reach expiration, because I won't be here around Christmas. So think, middle of December as a drop dead date.
We don't like to use the word drop dead in EMS. Okay, so our next meeting will be on January 8th. Hope to see you all there. And with that, I think we move toward adjournment. We have a motion to adjourn.
A motion to adjourn.
Motion. Second? Second? All in favor?
Aye.
All opposed? Thank you so much.